guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about some of the pathways in the adrenal cortex. It's going to be important for you guys to be familiar with these pathways because there are several differences in sexual differentiation that are going to be based off of different deficiencies and enzymes in this pathway that you are going to have to identify for step 1. So a quick overview here. Patients often present with atypical genitalia. So this could be a female presenting patient with an enlarged clitoris. This could be an indeterminate genitalia presentation, usually detected at birth. This is going to be your first clue that we will be talking about a difference of sexual differentiation pathways. And then most of these differences of sexual differentiation are going to result in decreased cortisol. As a result of this decreased cortisol, we will have elevated ACTH, which is made by the POMC gene, which also encodes MSH or melanocyte stimulating hormone. As we have more MSH released with this increasing levels of ACTH, you may see hyperpigmentation in these patients as well. Now, before we dive into the individual enzymes, let's quickly run through this pathway. So starting out with this pathway, we'll begin in the zona glomerulosa, and the zona glomerulosa is responsible for making our mineralocorticoids, things like aldosterone. Feeding into this pathway will be cholesterol. Cholesterol is the starting point for all of the hormones that will come out of the adrenal cortex. Cholesterol desmolase converts cholesterol into pregnenolone. 3-beta-hydroxysteroid dehydrogenase is going to convert pregnenolone into progesterone. Progesterone you may be more familiar with. And then one of our important enzymes that I'll point out here, 21-hydroxylase, is going to convert progesterone into 11-deoxycorticosterone. Our second key enzyme, 11-beta-hydroxylase, is going to convert 11-deoxycorticosterone into corticosterone. Then aldosterone synthase will convert corticosterone into aldosterone, and that is how we are going to synthesize mineralocorticoids through this pathway. So that's what's happening in this pathway as we continue vertically down through our zona glomerulosa. However, we also can transfer laterally to our zona fasciculata in order to create glucocorticoids out of the same pathway. In order to do this, we will use the third important enzyme that you guys should be aware of, 17-alpha hydroxylase. 17-alpha hydroxylase is responsible for this lateral shift from either pregnenolone to 17-hydroxypregnenolone over here, or from progesterone to 17-hydroxyprogesterone over here. 17-hydroxyprogesterone is an important intermediate that we can talk about later. But in either case, whether we are converting from pregnenolone to 17-hydroxypregnenolone or progesterone to 17-hydroxyprogesterone, 17-alpha hydroxylase is going to have the same job, which is lateral transfer from the zona glomerulosa to the zona fasciculata, so that we can then continue vertically down this pathway to create our glucocorticoid. 21-hydroxylase is again going to be helpful for continuing vertically down this pathway, this time creating glucocorticoids. So 21-hydroxylase is going to make 11-deoxycortisol, and then 11-beta-hydroxylase once again will come into the picture to create cortisol, which is our end product in the zona fasciculata. Moving laterally once more, we have 17-20-lyase. This is an enzyme that is going to create either from 17-hydroxypregnenolone dehydroepiandrosterone or from 17-hydroxyprogesterone androstenedione. 3-beta-hydroxysteroid dehydrogenase can also create androstenedione within this pathway. 18-beta-hydroxysteroid dehydrogenase can then create testosterone, one of our androgens that is going to be made by the zona reticularis. And then another important enzyme that you should be aware of, 5-alpha reductase, can convert testosterone into DHT or dihydrotestosterone, which will be important for virilization of external male genitalia. And then the last key enzyme that I want you to be aware of in this pathway is a peripheral enzyme, aromatase, usually found in peripheral or adipose tissues. And the job of aromatase is to convert androstenedione or testosterone into either estrone or estradiol, so making these virilizing hormones that were produced in the zona reticularis into feminizing hormones in the periphery. I know that was a lot to cover. Let's quickly recap some of the important enzymes we talked about in this pathway. First, 21-hydroxylase. 21-hydroxylase is important for making mineralocorticoids in the zona glomerulosa, in addition to glucocorticoids in the zona fasciculata. If you have a deficiency in 21-hydroxylase, then you would have a deficiency in mineralocorticoids and glucocorticoids. 17-alpha hydroxylase is an enzyme that is important for lateral transfer from the zona glomerulosa to the zona fasciculata. Thus, it is important for glucocorticoid synthesis. And if you have a deficiency of 17-alpha hydroxylase, you would get a deficiency in glucocorticoid, but you would still be able to make the mineralocorticoids which come before 17-alpha hydroxylase in this pathway. 11-beta-hydroxylase, just like 21-hydroxylase, occurs in both the mineralocorticoid and glucocorticoid pathways, but it occurs at a lower point in these pathways, so if it is deficient, the presentation will be slightly different. 5-alpha reductase is most active in the zona reticularis. It converts testosterone to DHT. If you'll remember, testosterone is responsible for virilization of the Wolffian duct, and that is why it is responsible for internal virilization, whereas DHT is responsible for virilization of the urogenital sinus and fold, so that is why it is responsible for external virilization. And if you have a deficiency in 5-alpha reductase, you still may get internal virilization because you have this testosterone, which was still able to be produced. However, the DHT wasn't produced, so you may have externally female genitalia or ambiguous genitalia. An important clinical tie-in here is finasteride. Finasteride is a 5-alpha reductase inhibitor. It can be used to treat benign prostatic hyperplasia, and that should make sense to you. If we are inhibiting 5-alpha reductase, we will have less DHT, so less stimulation for our prostate to grow. And then lastly, for enzymes, we talked about aromatase. Aromatase is an enzyme found in the periphery. It converts testosterone to estradiol, prevalent in adipose tissue. So if you have more adipose tissue, then you may have more aromatase activity, which can lead to higher levels of estradiol and gynecomastia in male patients. And then an important clinical tie-in here, aromatase inhibitors such as anastrozole can sometimes be used to treat breast cancer. And that should make sense to you because if we are inhibiting aromatase and we are decreasing levels of estradiol, we are decreasing stimulation to grow more breast tissue, which of course is helpful in the treatment of breast cancer. And then one last intermediate that I mentioned that I think it's important to be aware of is 17-hydroxyprogesterone. Remember, 17-hydroxyprogesterone up here is an intermediate, and why it's important is that it's commonly used as part of a screening test for 21-hydroxylase deficiency. So in patients where a difference of sexual differentiation is expected, they will commonly test these 17-hydroxyprogesterone levels, and if these levels are increased, that signals that we have a 21-hydroxylase deficiency. That should make sense to you because if we have very high levels of 17-hydroxyprogesterone, that means that they are building up behind a blockade in this pathway, and the enzyme that should be converting it into 11-deoxycortisol would be 21-hydroxylase. So if that enzyme is not working, that is when we would have a 21-hydroxylase deficiency, and we could test for that by seeing elevated levels of 17-hydroxyprogesterone. Now, I know that was a lot of information. I want to quickly recap what we talked about in this video by going through some memory aids. So the first thing I want you to remember is that all of our differences of sexual differentiation are autosomal recessive, so it's an easy inherited pattern to remember there. Next, I want to walk through a couple key rules that I think will really help you keep these different enzyme deficiencies and differences of sexual differentiation clear in your mind. So the first rule is, if the enzyme that is deficient begins with 1, then a deficiency in this enzyme will lead to hypertension. And the second rule is, if the enzyme ends with a 1 that is deficient, then deficiency of this enzyme will lead to female virilization. So I've written this out up here. We can kind of walk through this table here. So applying these rules, 21-hydroxylase deficiency, it doesn't start with a 1, so we are not going to see any hypertension, but it does end with a 1, so we are going to see female virilization. 17-alpha hydroxylase deficiency, it starts with a 1, so we are going to see hypertension, but it doesn't end with a 1, so we are not going to see any female virilization. Then 11-beta hydroxylase deficiency, it starts with a 1, so we are going to see hypertension. Then it also ends with a 1, so we will also see female virilization. You can kind of see, just working through this little pattern here, how it might be helpful when you are answering questions on step 1 to know what enzyme deficiency is linked with which features of blood pressure and or female virilization in a test question. And then how do they ask you about this on step 1? Well, something they might ask you is, a healthy 3-day-old infant is examined in the mother-baby unit. External genitalia is indeterminate for sex. Karyotype reveals an XX infant. Blood pressure is within normal range. What is the most likely cause of this patient's presentation? So we know that this is a differences of sexual differentiation question because it tells us that we have an indeterminate for sex infant. We know that this baby is XX but has indeterminate genitalia, so this is likely a female virilization question. Looking over here at our different types of differences of sexual differentiation, we see that 17-alpha hydroxylase deficiency, it does not cause female virilization, so we will cross that off the list. The question goes on to tell us that the blood pressure is within normal range. We should expect to see hypertension if this was a patient with 11-beta hydroxylase deficiency, so I'm going to go ahead and cross that off as well. And then lastly, the question asks us, what is the most likely cause of this patient's presentation? Since we have gone through this process, we know that 21-hydroxylase deficiency is going to be the most common cause of this patient's presentation. It is actually the most common cause of differences of sexual differentiation or congenital adrenal hyperplasia overall. So that is how I would answer this question. Now, I hope this video was helpful, and I'll see you next time.